Welcome to tonight. This is hopefully going to be a very quick guide to building an RACH telehealth map and relationships with the RACHs that you all attend. I think most of the people here are probably GPs that attend RACHs. If we got anyone else, I'll get you to pop in the chat box and let us know who you are and what your role is and where you're from. I'm assuming everyone's here is from the Gold Coast region, but again, if you're not, let us know. If anyone's having trouble seeing the slides also please speak up. All right, so firstly, we would like to acknowledge and pay respects to the traditional practices of the families of the Yagamba language region of Southeast Queensland. We respect their continued cultural and spiritual connection to country, waters, kin and community. I would also like to pay respect to elders past, present and emerging as custodians of knowledge and law. I'd also like to make acknowledgement for the Bindal and Wulkurugaba people, which is where I'm presenting from today in Townsville. So today we're going to go through a few things. Again, there's quite content heavy here. We'll have a couple of slides. We'll ask for a bit of feedback through the chat box. First, we'll go through an introduction to myself and my background. We'll have a little bit of a case discussion and look at where telehealth might fit into that particular case. We'll go through the considerations for telehealth and why telehealth, and then we'll look at logistics, including all considerations with the stakeholders. So hopefully by the end of tonight, you will understand a bit about the patient journey and impact on access to primary care and access to GPs. We'll discuss the abilities and limitations of telehealth and virtual care. We'll discuss required policies for practice in RACH, including privacy. We'll look at some of the platforms that we can use to deliver telehealth. We'll look at how to complete and hopefully implement a plan, and we'll look at some other things, including contact with tertiary care and my health record at the end. So a little bit about myself. My name is Chris Tomaschuk. I'm a GP in Townsville. I did all my training here. I'm now a practice owner and director at North Shore General Practice. My experience in aged care was probably a bit like everyone else's, particularly initially, and that I had a lot of patients that were scattered across different RACFs across Townsville, and it was very difficult to manage. Communication was very poor. It was hard to get out to patients sort of to and from work, and the after hours I couldn't really handle. I didn't intend to stay in aged care. However, a RACH opened up down the road from us where the practice is, and they asked if we'd be willing to take off patients. A few of the GPs at our practice put up our hands, and we ended up sort of falling into a model of care that worked really well in that we essentially look after the whole facility as a practice, and we share patients like we would in a normal GP practice, with one of us taking on the primary carer role and doing the CDM item numbers, but also, if one of us is there each weekday of the week, we can attend to acute care needs, and it really reduces after hours contact. It also allows us to develop a really good relationship with the RACH staff, and we've been able to implement a lot of good things, including telehealth. I've also got a role on the North Queensland PHN as a board member, and as a result of my work in the facility that we've got, I ended up doing a project with funded by the PHN up here with associated with Queensland Health and improving residential aged care and primary care and delivery into those services. So I've worked very closely with Queensland Health, and we've managed to get some funding through Queensland Health for some nurse practitioners for primary care support, which has been great. So I guess the first thing we're going to look at is the current lay of the land. What's the climate like? I think a lot of us, looking at this scenario, which is a very common thing. So we've got Olive, who's an 85-year-old resident who has a moderate cognitive impairment. She starts behaving a bit aggressively and pushes another resident, but the situation has de-escalated. The RACH staff mentioned that they've noticed that recently she's been peeing a bit more and then stinging on urination. However, that wasn't mentioned until the incident. You've been at the RACH already, but you weren't notified of this concern. They call you at 6 p.m. on your way home, or you've already left and you're trying to get the family ready for dinner. So I guess in this situation, how are you feeling when you hear the phone ring? Firstly, then I guess, if you do answer the phone, what information would you like to receive? Or if you don't answer the phone, is there any other way that you would like to receive the information? I'll give a minute or two to just type in the chat box with your feelings on this scenario overall and how you relate to this. I know a few of you may be away from the keyboard at the moment. All right. Well, I'll keep talking. I think this is a common scenario which here we go. Yeah, treat urine infection ASAP. I agree. Are we sure it's a urinary infection? I guess we need a lot of other information too. And when you get a call like this, it helps to have some context. You want a general set of vital signs. You want to know what's also led up to this in terms of urination habits, bowel habits. Let's see what else we got. Staff assess for UA. Yep, you want the UA and get the OBS and whatnot. Dipstick. Yep. I guess how likely is that to happen, particularly if it's after hours and there's maybe limited staffing. You might have agency staff who might not know where everything is. So often the call you'll get will have not much information at all, and you might be doing a phone order to a nurse and not receiving any contact with the patient or any other information. So I guess there's a lot to unpack here in terms of how do they deliver information. Like obviously it's great if they can collect it and relay it over the phone, but also if you've got access, say to their electronic records externally or remotely, you might be able to log into the chart and have a look at and see if a lot of that information is there. And we'll get to it in a sec. It helps to have obviously the underlying information for you to receive that. For you to make an informed decision on what to do for this client. I guess the other thing to consider, if it is a UTI, if it is likely that it's something simple as that, how do you treat it? Do you give a phone order for antibiotics, or can you log on to, if you're lucky enough to have the electronic medication charting now, that's made a world of difference. So yeah, electronic systems are definitely useful in this situation. So if you receive this call from say a nurse and you've given this background, you technically can't bill Medicare for this unless the patient is there and you're talking to the patient on the phone as well. So again, we'll look at how maybe we can develop a system where you can an agreement with the RACH or RACF that they might be able to have the patient involved in this care so that you might be able to claim Medicare billing for it as well. All right, so as part of the journey and a part of the telehealth implementation, we need to understand who our main stakeholders are and what their needs and wants are. As I mentioned before, I did this project with primary care delivery into RACH staff, and we really tried to get to every stakeholder, and particularly patients, staff, GPs, and allied health, to try and understand, what the needs and wants were. I think, firstly, to understand RACH staff concerns, there's a lot of this here we probably expect. So there's not a lot, like maybe 1/3 are actually satisfied with the level of GP access and care. They often want us 24/7, but that's not obviously what we can deliver. So there's some expectations there. So less than that, 1/4 are satisfied with GP responses to acute care needs, and less than 50% were satisfied with after hours response. And most of us GPs don't really have the time or availability to do a lot of after hours care at the moment, and often that is deputised. Interestingly, one of the things we found GPs mention is when they get to a ward, they can't find staff or information. But equally, the feedback from the RACH staff is that, the doctors are coming when staff aren't aware that they're coming, or they come an hour or two late. And that's some things that are beyond our control a lot of the time. But it helps to have a system in which way we may be able to give the heads up and let RACH staffers know if there's any concerns with us getting there at a certain time. A lot of the staff at RACH would like more in terms of governance support within the RACHs and with professional development. So there's a big role, particularly for upskilling and empowerment within the RACHs. And for something like that presentation with Olive, it really benefits to have staff that can really act on that and know what the required information is to pass on to us to make things a lot more seamless. So then we look at the residents' experiences. So we know that most patients that go into an RACH would prefer to keep their existing GP, and that's not always achievable. They can still visit us, within our practices, but that's, again, not always easy, particularly with transport. We found that about 1/4 would like fortnightly reviews. However, that's probably pretty unrealistic, as most of our patients wouldn't see us fortnightly within our practices. But equally, about 1/4 of them would be happy only with occasional attendances. Most patients want to be seen, though, by their GP at least every 3 months, and most would like to be seen within 1 to 2 days for acute care needs. Now, on a face-to-face, that 1 to 2 days is, again, pretty unachievable for most of us. But if we can work in telehealth and virtual care into our days and put time aside for this, then that might be a lot more achievable. Interestingly, we explored a lot of the patients, elderly patients' attitudes towards telehealth, and the vast majority of them are extremely accepting of it. We've had a lot of patients say that they're quite accepting of care over an iPad or a device rather than face-to-face. They much prefer face-to-face, but particularly, if it's something for acute care needs, then they're quite willing to use a device or use telehealth. So residents' experiences in terms of communication, so they can see with GPs, 1/3 think it's very easy, but equally 1/3 are quite difficult to communicate with the GPs. The nurses within the RACHs were a little bit better, 45% very easy, 10% difficult, and communication with allied health professionals, again, was mostly pretty neutral. What are our needs? What are our wants? Or what are we doing at the moment? Again, this goes through my project, and we looked at I looked at a lot of for surveys through Townsville and through Australia. So this was distributed through the GPs Down Under and the Doctors in Aged Care Facebook groups, and we got over 100 responses. And the Townsville region was quite similar to the rest of Australia. So I think, the challenges we face are quite equal. Most of us are still doing face-to-face and have regular ward rounds. However, there is quite a lot of ad hoc visits throughout the day, going to or returning from work or to home, and attending after hours and on the weekends. Most of the contact is actually weekly. And then, telehealth is the numbers there match pretty similarly to what we're doing in a day-to-day practice, with the percentage of telehealth being used in aged care at the moment, and most of it's phone contact. So what are we satisfied or what are we unsatisfied with? I think it's pretty clear, and we've all had experience with this. Most of it is the electronic stuff. So it's the medication charting, it's the IT. Communication from private hospitals was brought up as a big issue. We did a workshop last week with a lot of the RACH staff, and again, communication with private hospital was up there as one of the biggest pain points. We find a lot of concern, particularly with the staff support within the RACHs, and obviously with the administration workload. After hours was surprisingly pretty neutral. There's a lot there that we are pretty happy with, things like palliative care and communication with the RACHs and families. Most of us are pretty happy with that. So what do we want? The main things is the electronic access. So the electronic medication charting, cloud-based or remote access to medical software, also remote access to the RACF software. From what I understand, it sounds like most of the Gold Coast seems to be electronic now in terms of their charting and delivery of information, which is great to see. And most people have remote access. So if you don't, it's really important to try and push this with your facilities. You can't do telehealth, you can't do virtual rounds without the information available. So it's really important that you have that underlying information there. And this is just a bit of a snapshot at the moment. So the most recent information about the types of telehealth that are being done. So again, about 18% of the care we deliver is via telehealth at the moment, and the vast majority, about 90% of this, is via telephone. We don't tend to do a lot of video consults, but particularly when you're looking at things like chronic disease management and facilitating that through an RACH, that might be something we need to consider. The specialists are much more willing to use video calls. In particular, psychiatry, or over 50% of the telehealth is video calls. So GPs lagging behind. And a lot of that has to do, I think, with their day-to-day business and the time it takes to actually connect to a video link. It might be 2 or 3 minutes per patient, but at the end of the day, that's a lot of time wasted trying to get onto a video call compared to just picking up the phone and calling. Often in my practice, I will start with a phone call and then convert the video call. However, in the RACH space, particularly if you're organising a virtual rounds, then a video call is going to be probably the better option, especially if you've got someone on the other end that's able to go room to room or bring the patients in one by one. All right, so looking ahead and planning a telehealth journey, just another quick exercise if you want to type in the chat box about what reasons or what benefits you see in telehealth at the moment. I'll give about a minute to get that done. Yep. Definitely helped during COVID, didn't it? Absolutely. Yep. Much quicker response if needed. Yep. So convenience and preventing hospital admissions. So again, it's about that access, isn't it? Yep, more consistent care, more immediate care, again, that acute access. Yep, it is hard. Most GPs will have some on the day appointments that they sort of keep, and it's handy to have those available if you are fully booked to try and sneak some aged care in there. But often they fill up pretty quickly as well. All right, so yeah, a lot of these have been mentioned. So it's, essentially improve access, both acute and chronic needs, after hours care. Again, the electronic side to it, so the prescribing, referrals, pathology and imaging, save unnecessary travel, both for the patients and for us, improving continuity of care and linking with other virtual care, including specialists. So what do we have to consider? Well, the first thing is, what is virtual care? What does it encompass? It's not just a telephone consult or a video consult. There's a lot of other considerations, including how do you communicate, including email, secure messaging, store and forward technologies, and the emerging remote monitoring. I guess the biggest thing, we're all pretty considerate of this, is that telehealth is not a direct replacement of face-to-face care. So telehealth is there to supplement care. It's not there to replace it. We shouldn't be doing the majority of our care online. We should still be, attempting to do the face-to-face stuff, because that's the best way to practice. But it certainly has a definite role in improving the access and supplementing the face-to-face care. As I mentioned before, it's important to have the underlying infrastructure. You need the underlying information and the remote access to be able to successfully introduce virtual care. And you need a collaborative approach. So this needs to be discussed with RACH staff and management on how you're going to deliver telehealth into the RACHs. And not just again, video or phone consults. How do you choose to receive information? Do you prefer a phone call? Do you prefer an email or some sort of secure messaging where they can deliver information quickly and efficiently to you so that you can make decisions, particularly on acute cases? So it's really important to develop those relationships with the staff, which sometimes can be a bit difficult with the amount of turnover within RACHs. And I've found that particularly up here as well. I assume it's the same on the Gold Coast, that you just get one thing and one system up and running, and then all of a sudden everything changes, management changes, and you've got to start from scratch. So sometimes that can be a little bit painful, but as long as you've got a clear guide, hopefully it's easy to re-implement if things do change. All right, so what do we need to consider with delivery of virtual care with regards to the patient? So I guess the first thing is what sort of technology, or what is the patient able to use? Do they use their own technology? Do they have a phone or an iPad you can contact them on? Or do you use an RACH device? Prioritize the privacy and confidentiality of the patient. We'll talk a lot about that in a second. We need to obtain consent. So there's a couple of types of consent. So you got explicit and implied. A lot of the stuff we do is implied. So if a patient is starting to talk to you about, has arranged a telehealth appointment and starts to talk to you about the medical concerns, and that they've given you the consent, well, it can be implied consent. You do need to make sure that you've got the right details and you're talking to the right person, and confirm the identity of that person before you can consider that consent. You need to consider some issues that patients might have. So if a patient has deafness, there might be an issue delivering telehealth, and you might need to look at other things. There are obviously devices and hearing aids that can be Bluetooth connected, which makes it a bit easier. Otherwise, you might need someone in the room to help translate information. The needs of patients with dementia, so that's often a bit of a tricky one. You don't want to be shoving a phone or a device in front of a person with dementia. They'll probably get confused and agitated. So often it helps to start from afar, have, again, staff helping, and maybe observe them from the doorway. They get someone there that can relay information about that patient. Yeah, so you'll often need someone on the other end, hopefully medical staff, but maybe there'll be a next of kin or family in there as well to help relay messaging from the health providers to the patients and back. And then you can use interpretive services. There's interpretive services set up for telehealth. Again, we'll have some links to resources there later. So privacy, this is important that we understand privacy. A lot of what we do especially online, has the ability to be accessed externally. And, there's been lots of issues lately with breaches of confidentiality and people hacking systems to get information, and obviously the ramifications of that. So the privacy regulates the handling of personal information, and it's a right enshrined in the Privacy Act. In each state and territory has their own legislation. In Queensland, it's governed by the Office of the Information Commissioner. There may be some people from New South Wales here, so you'll have a different organisation. There's no specific confidentiality legislation in Australia, but it's governed by common law of duty of confidentiality, which is rooted in other sources. So confidentiality practices ensure the protection of information conveyed in confidence and not publicly available. And it obliges health professionals to limit access to information discussed in confidence. So there's three sources. The duty of confidentiality comes from three sources: statutory law, common law, and ethics. So we need to consider, potentially what harms can come if a privacy breach is made. I think most of us understand this pretty well, but things like identity theft, financial fraud in particular could happen in the RACH space. And then for us, it's loss of business, potential damage to reputation, and that type of thing. If there is a breach, it's important to obviously contact your MDO and indemnity lawyers if you believe there was a breach, and it's important to do that straight away if you think there was something. You will get in a lot more trouble if you try and sweep things under the carpet than to come out early. So it's important to let people know and to have a plan in place if that happens. So when is it appropriate to breach privacy and confidentiality? Again, I think as GPs, we're pretty on top of this. So obviously, for secondary purposes that are related to the primary purpose. So if we need to discuss a case, again, with consent within our colleagues or to a specialist, that's considered normal use of information and not a breach. If we have thoughts that there might be suspected unlawful activity or a serious threat to life or health or safety of an individual, again, that's a reason to breach confidentiality, or if there's overseas disclosure in accordance with a law, it's permitted. So this is a couple of resources. So the Office of the Information Commissioner has an online privacy course, which doesn't take very long to do, maybe 10-15 minutes. So if you want a really good understanding of what privacy is and what's required, you can click on that QR or hold your phone up to that QR to go through that course or get the link to the course. And Medicare also has a good privacy checklist to go through. So again, those resources are there. This video presentation is being recorded if you need to go back to it, and we can probably send out some resources after this presentation as well. All right, so within the RACH itself, obviously there's a lot of considerations that need to be made. The first thing is each RACH should conduct a digital readiness and maturity assessment. So they need to know what they need to do to be able to deliver telehealth within the facility. It's obviously sometimes hard for us, particularly with internet connections. Do we use our own internet or phone connection? Are we able to access their internet? And if we are, we need to make sure that works. It's probably the biggest issue at the moment, in particular with the way buildings are set up and brick walls and whatnot. It's very hard to get a signal throughout a lot of the RACHs. So we mentioned it before, but it obviously helps to have offsite and remote information available. So we need to be able to access electronic records remotely, and we need, the ENRMC is a huge benefit to us if it's available. It's really quite difficult to manage medications remotely if you don't have access to that. The RACH needs to have devices available to deliver telehealth, and that might be tablets, laptops, phones, and obviously other things that might go with it: trolleys, headphones, and headsets. Internet connection, obviously very important. Staff. So again, if you're doing telehealth to an RACH, you need someone on the other end to operate that. This doesn't necessarily have to be the RACH providing the staff, but it certainly helps. And if there's someone that's already designated to do a rounds with a GP face-to-face, and it makes sense for that person to be available for a virtual rounds. There are organisations that will use their own nursing staff from their own practices that send out to do telehealth, but I don't think that's a very cost-effective option at the moment with the way things are set up. They need to have a privacy management plan and policy and privacy officer as well. And then what do we need to consider? So the first thing is our infrastructure. Again, much like the RACH, we need to make sure we've got a good internet connection. Webcam, I find it really helpful to have multiple screens. So if I'm doing a telehealth or a video consult, I will either have my laptop on or connect through my phone to an app to do the video consult, and I'll have another computer or screen open to the medical records that I need to access. Headsets are also a good idea. Helps obviously with hearing what's happening on the other end, and also helps with privacy and confidentiality. We need access to information. We go over this a few times, and yeah, we need to have that electronic access, electronic referrals, pathology, imaging, scripts, also very important, and also setting up how you want to deliver information in between patients, and that might be email, SMS, secure messaging, and phone calls. Nursing support. So nursing support helps in the way of chronic disease management and doing care plans and CMAs. I've just got someone in the chat. So how does the ENRMC work? So the Electronic National Residential Medication Chart is being rolled out, or should have been rolled out in the last sort of year and a half. So this is a electronic medication chart that acts as the prescription, acts as the dispensing software for the pharmacy, and acts as the I guess the dispensing software for the RACH as well. So it's a one-stop shop. It stops the duplication that you get with writing on paper charts and uploading. For example, the RACH that I go to in Townsville only just went to ENRMC. Prior to that, we were writing on an MPS form that would get uploaded or sent to the pharmacy. They'd dispense off that. The RACH would then upload it to their own software for dispensing on their end, and we'd have to enter it into our medical records. So the ENRMC we use is BestMed. We just enter the medication onto that software, and that's all we do. There is one exception to that, which is S8s. So you still enter the S8s onto the ENRMC, but you also have to provide a prescription to the pharmacy for that. And that's due to laws, the current laws within Queensland, which should be changing. I hear there is movement to change S8s so that we can do the authorities through the ENRMC software. So hopefully that will come in soon. But currently, if you chart an S8 or an opiate, you have to do it on BestMed and then send the script to the pharmacy as well. But it cuts down obviously a lot of the administration work for us, and it's a massive improvement for the delivery of safe medications and reduction of medication errors. I was pushing our RACH to get it for about 1.5 years before they finally did. So again, if your facility doesn't have the ENRMC, definitely push it to get them. Yeah, so S8s is still the issue within the electronic charting, but still it's a lot better than what we were doing previously. And hopefully they resolve that situation too, with having to provide scripts. But yeah, you will still get lots of script requests for S8s. All right, so obviously we need to consider our privacy management plan policy and having a privacy officer. So that's part of that privacy training you can do. They suggest you have a privacy officer, someone to go to within your practice that can manage any privacy issues or concerns. So other primary care, including allied health. So obviously they can do telehealth as well. They don't unfortunately, apparently get funding for delivering telehealth services, but obviously the funding is changing within the RACHs, and they're all a bit stressed about this. There's also the Medicare funding through care planning that, you know, if you want to do referrals through that, but again, I don't think they can access virtual care. All right, so security, obviously very important in making sure that confidentiality and privacy is maintained. There's a number of different things that we all need to consider. Obviously, the first one is password protection. End-to-end encryption is preferred, but it's important to mention that although the message is unlikely to be intercepted between each point, if you've got a laptop open and sent an encrypted message, it's still accessible at each end. So if you leave a laptop open with patient information up at an RACH, someone can walk by and still see that. So end-to-end encryption helps, but it's still important to consider the factors that might be on either end of that. Multi-factor authentication is a must. So that's often when you're doing your remote access, it's important to have some sort of multi-factor authentication. And the most common ones are things like Geo, Boardrock, and obviously Authenticator. It helps to have a very good IT support and consent. So consent is, again, key here. If you are using things like email to send information, it's important that the patient understands that that's not secure. They may still consent to you using email as a valid form of communication, but that needs to be clear and charted. And again, breaches, you need to have a clear policy on what to do if you feel like there's been any breach of confidentiality there. All right, so setting up the virtual consult, what do we need to consider when everything else is set up, the infrastructure is laid down, and what do we do next? Just again, quick in the chat box, what numbers do you feel comfortable doing virtual care within these scenarios? So I'll get you to type in the chat box just the numbers which you'll feel comfortable with. All right, we've got a 3, a 6, and an 8. Two, 6, and 8. All right. Yeah, so I guess we all have our different tolerances here. Again, when we did this exercise last week, it was all pretty similar as well. So advanced care planning, probably not ideal to do over telehealth. That's a bit more personal and obviously not urgent. So that's a thing that probably can wait for face-to-face. Potentially could be done telehealth if there was no other option, or if you're working remotely and couldn't get to that patient within a decent time frame and there were concerns coming up. So recent forward severe back pain, again, you want more information there. Simple UTI, again, with the information, you might want to consider a telehealth consult. New onset of cough, shortness of breath. No one would really feel comfortable doing a telehealth there. Alzheimer's with recent behaviour changes, that potentially could be done initially as an urgent thing over the phone just to get a plan in place, but I think face-to-face is definitely warranted. Medication reviews, yes. So chronic disease management, there is item numbers. for video consults for chronic disease management, so 731s. So you can actually, well, it's got a, I can't remember what the number is, but it's got a similar item number for video consults. And the MDT case conferences can also be done telehealth. So logistics and workflows. So this is, again, is something that you need to communicate with the RACH for. The administration side, if you're booking telehealth consults, whether that's a virtual rounds or ad hoc, who are they being booked by? Is that being booked by the RACH? So particularly with rounds, they're the ones that are identifying the patients that need to be seen and then delivering that when you get there. But perhaps it is better to have them deliver that, say, the day before, if you've booked off time for a virtual round, to the practice, and the admin staff at the practice can then put that into your address book. I think it gets confusing if you're trying to use anything other external. I know there's other GPs around there that will use other programs that might be able to book appointments into, like Outlook or Galaxy and that type of thing. But I think it helps to have it within the medical software. Communication preferences. So again, how do you want to be notified of patients? Are you using email, secure messaging? I don't know if anyone's used it, but Better Consult also has the option of entering patient data prior to appointments. That's quite useful. And Better Consult's a free thing that app that feeds into best practice, and they're also trying to get a web-based one that can be used with MD. So yeah, how's information being relayed, recorded, and followed? How are you doing the rounds? Is it, set rounds? Is it ad hoc? Phone versus video consult? Again, if you're doing a rounds, it actually probably makes more sense to do a video consult. And then where are you doing the consult? Are you doing it at the resident's room, or is there a consulting room in the RACH that they're going to bring patients into? So again, all this stuff is important to discuss with the RACH staff and management, because it's going to differ from practitioner to practitioner to RACH to RACH. So the telehealth platforms, I'm guessing all of you are pretty familiar with different telehealth platforms, but obviously we use our phones normally within the practice. But if you're using it externally or through your mobile, it's important to use #31# to keep your number hidden. So #31# will, and then the number following that will hide the number it's calling from. There's various video platforms. So obviously we know things like Skype, FaceTime, WhatsApp. There's more business-centered ones like Zoom and Microsoft Teams. And then the medical ones, Health Direct, which is what I use 100% of the time. I love the app, and it's available free through, all you have to do is contact your PHN to organise that. And there's also GP Consults, which a lot of us were using in COVID. It's what I started using when COVID hit, but I switched to Health Direct. I'm not too sure what GP Consults is like at the current time, but Health Direct has a lot of cool features. You can share screens, you can draw pictures, you can share results and that type of thing. And then the clinical software, there's a few clinical software programs that are integrating video platforms into the software. And then once again, we can use things like email, SMS, secure messaging. But again, you need to, if you're using these platforms, you need to make sure that you have the patient consent and understanding that you're using them and exactly what information you'll be sending. So this chart is from the States, but it sort of breaks down the security of each of some common platforms. So you can see that there's some sort of iffy ones like Facebook Messenger and Instagram Messenger, which we'd probably expect. I like Zoom as a business platform, and you can configure it, and it ticks just about all of the boxes. A lot of people use Microsoft Teams, but you have to just understand that's not end-to-end encrypted. So if you're using that, you need to let the patient know that there is a potential that it can be intercepted, although it's quite low. All right. And again, I think most of us understand the eligibility of telehealth. So to do a telehealth consult, patients need to have had at least one face-to-face service in the 12 months preceding. or it can be done by a health professional at our practice, or if we've got a approved medical deputising service, they can video or telehealth the patient. And the established relationship requirement is a rolling requirement applying to every telehealth consultation. There are some exceptions. So patients receiving an urgent after-hours service, patients of medical practitioners of an Aboriginal medical service. So if you're working out of an Aboriginal medical service or ACHO, you pretty much can call any patient. Obviously, the COVID rules are there, so you can, if someone's got COVID, you can telehealth them even if you haven't seen them before. And then flood-affected areas are also eligible for telehealth. So telehealth billings and rules: for us to claim the Medicare item numbers, the patient must be present and have consented. So again, if someone's calling you about a UTI and the patient is not present during that call, then you cannot bill Medicare for that. And they need to have consented to the consult, and also have been financially consented, particularly if you are private billing. You're still meant to consent that they allow Medicare to take the billing if you are bulk billing. Other considerations: obviously we get a flag fall if we're doing face-to-face. We don't get that with telehealth item numbers, and the telehealth numbers do not contribute to the aged care incentive payments. So, you know, if we're needing to get to 180 patients to get the full back eye PIP, then telehealth, if we're doing a lot of telehealth, we may not get there. And the 30-20 rule, which I believe is coming in October. So you can't do more than 30 telehealth consults on a day for 20 days of the year. Otherwise, that you will get automatically flagged and audited. Does everyone understand that? If you don't, you can put your hand up or type into the message box. All right, so the consultation call, we need to confirm the patient details. So 3 points of identification, which is often name, date of birth, and address. We need to confirm the attendees. So again, if we're doing the RCHs, there's high likelihood there's going to be someone else in the room. So we need to confirm who they are. We need to get consent. We need to document the consent as well, including financial consent. Once we've gone through the consult and addressed the issues, we need to summarise the key points and what happens next, and ask the patient if they need anything clarified and check their understanding. Following the consultation, so again, documentation is key with anything we do. It's ideal that we have documentation within our own software and the RACH software. So if you're lucky enough to have electronic access to both, it's simple copy and paste. Otherwise, a lot of practices still will print out one or the other and then fax to the other place. We need to ensure documentation of consent, the location of the patient, any attendees, including anyone coming or leaving, and what times they come in and leave. Obviously, our clinical notes. Mention the outcomes, who is responsible and for what action. And then we can do medication charting if we're lucky to have the electronic medication charting. That's a simple process. And then any electronic referrals or paper-based referrals. If you're using a paper-based referral, it's often helpful to obviously send that referral through to the RACH as well. One thing that's not mentioned there that I should mention is that we're meant to, during each virtual consult, you have to write the reason that was a virtual consult and preferred over face-to-face care. And that might be something as simple as, you know, improving the access. And then we need to understand, you know, what to do when things go wrong. Obviously, we all run late quite frequently. We need to have a plan for that. And that might be as simple as sending admin a message to relay to the RACH staff that you know, we're running half an hour behind. So doctor will call then, and you know, that way the RACH staff can get on and do the things that they need to do and then come back to it later. There's going to be internet failures, there's going to be technology failures, so you need to have a backup plan what to do then. You know, it might be things, lines dropping out and using hotspot on your phone. So it's important to have plans to do of what to do when things don't work, and have a backup plan. Need to have EPOA and family considerations, consent and privacy, particularly with people who may not be able to consent. So for delivering telehealth for someone with dementia, obviously their EPOA will need to consent to that. And you might want to do a blanket consent that states that the family is happy for those consults to happen, or the EPOA is happy for those consults to happen. But any changes you make will likely need to run back through the EPOA. I had a question about public guardian at the last forum, and that's a bit of a tricky one as well. Obviously, the public guardian is responsible for medical decisions. So I think if it's something acute that the RACH staff needs addressed, I don't see any problem with being able to deliver telehealth there and then relaying the management plan back to the public guardian. But yeah, that is a consideration that you'll need to make. I think, once you've got everything set up and the systems in place, you need to test them to make sure that things work, and that way you can work through some of the troubleshooting that might occur. All right, so other considerations, as mentioned before, a lot of the, do we have a hand up? No. Sorry. Yeah, so a lot of the pain points we have is actually from information not between the RACH and primary care. It's actually through tertiary care and other providers. So how do we improve that flow of information? Now, the My Health Record traditionally has been pretty limited in the amount and the quality of the information available. Often it's not really up to date, but that's improving, and we've just seen with the budget, there's a whole lot of funding being put in to try and improve that. Now, the RACHs are all being onboarded to the My Health Record, so they should now start to have access to the My Health Record, which hopefully should improve a lot of the access of information. It's important from our end and our colleagues' end that we have updated information on there as well. So particularly when patients are being admitted, it often helps to have access to a recent health summary there that we can go through and get the required information that we need. There are obviously discharge summaries and pathology and imaging coming through tertiary care that we'll be able to access through that as well. Oops. All right, so the My Health Record. So this QR links to the implementation of My Health Record into RACH. So you can click on it if you like, but it will give you the framework for My Health Record in RACH. So that's definitely coming. What it contains is an online summary of individuals' key health information. So it's controlled by the patient. It's accessible anywhere in Australia, and it's protected. You can access it through your clinical software or through the National Provider Portal. You can only adjust or upload information through the clinical software though. So if you're accessing through the National Provider Portal or PRODA, you won't have the ability to upload information there. So what does it contain? Consumer documents include a health summary, any personal health notes. So this is stuff they can enter. You can now upload advanced care planning, advanced health directives and the sort up to the My Health Record, and emergency contacts. There's Medicare documents. So patients can access any of the billing we do, including MBS or DVA items, and they can access the immunisation register. So what can we upload? We can upload shared health summary. Obviously, discharge summaries can be uploaded, and pathology imaging reports. That's a very hit and miss, I find still, and prescribing and dispensing records as well. Again, medications have historically been not accurate or not updated, but that's one of the features that it seems to be coming through. Yeah, so they need to be able to access there. Yep. All right, and looking towards the future, you know, a lot of the care is going to start to have a lot of devices that we can use, and things like digital tongue depressors and otoscopes and that type of thing. There's quite a few innovative things coming through in virtual monitoring and blood pressure and vital signs, and even just patient forms where they can enter their symptoms. So a lot of what we're doing virtually is going to have a lot more support in the near future, but it's important to get the basics right with the telehealth and the virtual care first. All right, so this is basically the last slide. So we flew through it and we got there in time. So we got 2 minutes to spare, but we'll use that last couple of minutes. Just if anyone has any questions, please put your hand up or type in the chat box. I'll leave these slides up in case you want to hold your phone over them. So the resources there from the RACGP regarding telehealth setup, Australian Digital Health Agency and Health Direct, they all have a lot of great resources on how to set up and implement virtual care in your practice. So I'll leave it open for a couple of minutes to just take any questions if anyone has any. Otherwise, we can call it a night and go watch the Women's Origin. Hopefully Queensland will get up tonight as well.
Hey, Dr. Chris, thank you so much. I really appreciate you, and I'm jumping in to send the link into the chat for our feedback survey.
Yep.
Please, everyone, you can.
Yeah, before you go, if you can all click on that link, just provide a quick feedback so that we can plan and future events. I'd like to thank AgPal and Gold Coast PHN for inviting me along too. It was great to talk to you all, and hopefully you've got some things out you can take and go to your RCHs and implement some of this into your day-to-day practice. It does make things a lot easier.